I lived in France for a while, and one of the principles of the French Revolution was that higher education should be free to everyone, all the way through medical school.
Sure.
And the doctors over there, they're paid like normal people. They're paid like engineers and lawyers. But here, the doctors make $100,000 or more a year.
Well, be careful. Only some doctors. Many don't. Many make a lot less in
I think the average is $100,000.
Okay, that may well be.
Yeah. Again, you have to look at, there's definitely in this country, specialists, for example, make a lot more than specialists, for example, in Canada or in France or in Sweden. That is true. But in terms of primary care, actually in Canada, primary care physicians make more money than they do in the United States. So it really depends on what you're talking about. The other thing you have to remember is their overhead. The overhead expenses in the United States are far greater than any other country because they don't have to deal with these multiple payment mechanisms where we do in this country. So there's all these other things that we have to consider in this country when you look at how much doctors are paid. There's also the huge malpractice costs that are much higher in this country. So
the other point worth making is when you come out of medical school in America, you have hundreds and hundreds of thousands of dollars worth of debt. As you just pointed out, when you come out of healthcare, out of school in France, you're debt free, and that's a real issue.
I think that's an important factor in the cost of. Sure. And more poor people from poor families could go into medical school, and you would have more specialists. Right. And then the salaries would come down because there'd be more competition.
Right, and some of these things would have to be dealt with at a national level. If we were going to fully fund medical education, we would have to do that at a national level. I mean, I think that if we did do that, however, we could also change the specialties because, right now the government pays a good percentage of for residency training through the Medicare dollar. But what we need to do is increase the number of financing of primary care slots than we do right now. So, but we would have to do that at a national level. That'd be tough to do at the state level.
You mentioned the war. We're spending, I think, Little Vermont spends $1.5 billion a year. That's our contribution toward the war in Afghanistan and Iraq. And if we didn't have to spend that, that would go a long way toward paying for a lot of this.
Sure. But again, even if you just looked at how much we're spending on medical care, there's a whole lot of money in just the healthcare spending alone that we don't have to even deal with other issues in order to fully finance medical care for every single Vermonter. I mean, I just want to go back to, how would we do this? As Peter was mentioning, if we simplify the way we pay for healthcare, we collect the money, we put it in one fund and pay for healthcare directly. We could actually cut administrative costs. Now, there have been estimates as little as $50 million a year up to $500 million in Vermont alone on savings on administrative costs. But we do know that with the money that we would save, we could buy eye care, prescription, doctor, hospital, mental health, and rehab for every single Vermonter with the same spending. And in fact, there was an estimate a few years ago that showed we could spend 5% less. And when you consider how much were we talking about the deficit this year, was it $119 million?
We just cut $158 million from the budget this year.
Yeah. So I mean, we're talking hundreds of millions of dollars that we could save in the state of Vermont on administrative costs that could be spent on health care for all Vermonters.
One big expense that's not covered is dental care. Is that one of the considerations that might be in the new our new single-payer system?
I believe dental care is listed as one of the things. And that was in an estimate years ago. Dental, there wasn't certainly cosmetic dental care, but dental care that was medically necessary was actually included in it. I believe it's covered.
It's covered by the existing Catamount Health, Dr. Dinosaur's covering dental, and dental is a part of. You can't go around with 3 rotting teeth in your mouth and be a productive member of this society. So dental is an important piece of the health care.
It's also a medical problem. One of my first experiences as a medical student was going in and seeing a young boy who was covered under the state Medicaid system in New York State, and I think he was about 8 years old, and he had a congenital heart defect, and the dental wasn't covered, and he had an infected tooth, and the infection actually went into his bloodstream and infected his heart valve. And he ended up with something called subacute bacterial endocarditis and ended up for 2 months in the hospital on IV antibiotics. It is a medical issue. In addition to it being, you know, a comfort issue, it definitely affects people's health also. It should be covered in any sort of comprehensive healthcare plan.
I live in the old north end of Burlington, and that's a poor area, and you see many people walking around with missing teeth in front and the sides.
Right.
And implants are possible, and if they were paid for, it could make a big difference.
And it's cheaper to pull them, and that's why many of these folks end up, instead of getting their teeth taken care of, you know, filled and whatever, it's cheaper to pull them, and that's what they end up doing. So
it's pretty extraordinary when you figure that with advances in dental care, even since I was a kid growing up in Vermont, you know, if you get the care early, the chances of you getting a cavity are reduced exponentially. And we know that preventative care works every single time, dental too. It's cheap.
And it's harder to get a job when you're missing some teeth. It really, there's many other indirect effects to that. I mean, it's really ridiculous when you consider, again, that we have more than enough money floating around in the healthcare system to fully fund dental care for everybody.
I hope they will fund implants also, because that's part of the, even when they do fund the dental, they usually exclude the implants.
Well, and see, and this is really what we need is a process to look at how much money we have, how much money we can collect for health care, and what it is we're going to spend on. We don't even have that process right now, and that is exactly the process that Dr. Shao is undergoing right now. And he's going to present 3 different plans and cost them out, and how much it would cost under each particular plan, the public option, the single payer, and then a third option that he's going to look at. But we need a process. Right now we don't have that, and it's sort of this willy-nilly paying for medical care, and no wonder we're in such a mess, because we don't have a healthcare system.
Last time I talked with Peter, we talked about the health system in Oregon, and maybe you would like to comment on it. For many years now, Oregon has been the only state to have a death with dignity law, which allows doctors to help their terminally ill patients determine the time and circumstances of their death. Some countries in Europe, such as Switzerland, also have such laws. It's been suggested that Vermont should enact its own such law. What do you think about this? Have you encountered this in your practice?
I have encountered, yes, I've encountered people who really wanted to have their own, handle their own destiny in that way. And I do believe in that. I mean, that's certainly something, a personal belief of mine. And I do believe that people should be in charge of their own lives and their own death.
I support end-of-life choices, Terry, and I had an experience just recently. One of the great things about running for governor is that you get to talk to people all across the state. And I had a sad but interesting conversation with a Vermonter in Ludlow recently. And she said to me, "Where are you on end-of-life choices?" And I said, "I support it." And she said, "Thank you. I'm going to vote for you now." And I said, "Why?" She said, "I have ovarian cancer. I've survived longer than, my doctor calls me a miracle. I've survived longer than I should have." And she said, "I'm feeling great, and I'm doing everything I know how to stay alive every single day." But she said, "I do know that in the last few weeks of my disease, this particular cancer is a really uncomfortable and unhappy way to die." And she said, "I would like, when that time comes, I'm staying on this earth as long as I possibly can, as all of us wish to do. But when my time comes, I want to have the choice about the last few days of my life. And I can't imagine in my wildest dreams why government would get in between that woman that I spoke with in Ludlow and her doctor." I feel the same way about, and Brian, by the way, opposes this. He also opposes a woman's right to choose. I will defend until my dying day the choice that a woman and her provider make about their reproductive rights. But these are really important issues that should also be discussed in this campaign. You know, if we elect Brian Doobie, he'll be the first Republican statewide office holder, and I'm including George Aiken, Jim Jeffords, Dean Davis, Dick Snelling, Jim Douglas, Bob Stafford, who don't even believe or that it's not the government's job to get in the way of a choice between a woman and her provider about reproductive rights and abortion. Brian believes government should regulate that. I don't. I also feel that way about end-of-life choices.